Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Welcome to the deep dive. Today, we're tackling something really critical, the link between mental health treatment and physical health outcomes.
That's right. We're focusing on a specific group facing major challenges.
We've got some compelling sources, especially a key Danish study, the HISTORI trial. It seems to offer maybe a real solution to a pretty devastating problem in medicine.
It's a classic difficult situation, isn't it? Where the necessary treatment itself causes serious, sometimes life-threatening side effects.
So this deep dive is about digging into the data, finding out if we can finally manage those risks properly.
Precisely. Let's see what the evidence shows.
Okay, let's start by just outlining how big this problem really is. When you look at patients with schizophrenia spectrum disorders, schizophrenia, schizoaffective disorder.
Fix the typo as well.
Right. They face this shocking reduction in how long they live. We're talking, up to 15 years less than the general population?
That's the figure, yes. A 15-year mortality gap. It's huge.
Staggering. And it's not the mental illness itself that's directly causing this, is it?
No, not primarily. The overwhelming driver is physical illness, much higher rates of cardiovascular disease and type 2 diabetes. That's what's behind the early mortality.
It's a gap we really shouldn't see in modern healthcare.
Absolutely not.
And here's where it gets really tough. The sources are clear. This isn't just about lifestyle factors, although they play a part. There's a direct drug connection.
There is. Many patients depend on second-generation antipsychotics, the SGAs, to manage their symptoms effectively. They're often essential.
But they come with this metabolic crisis as a side effect. It seems almost unavoidable.
That's the crux of it. These SGAs are known to cause rapid, significant weight gain, and they also severely impair the body's ability to handle glucose.
So the very medicine that helps keep their mental health stable is actively pushing them towards diabetes and heart disease.
It's a terrible trade-off, a medical catch-22, really.
Which brings us squarely to the HISTORI trial. Its mission was basically to ask, can we fight those metabolic risks, the weight gain, the blood sugar issues, without messing up their psychiatric treatment?
Can we give them something effective and safe? That was the question.
And today, we're extracting the key findings for you, what this trial really means.
It's interesting they focused on semaglutide.
Right. That's a GLP-1 receptor agonist, already pretty famous for weight loss and blood sugar benefits in other groups.
Exactly. But the researchers needed solid proof it would work and be safe specifically in this complex, high-risk population, a group that often faces, significant barriers to getting consistent medical care.
Okay, let's dive into the trial itself then. The design. Who are they actually studying?
They were quite specific with the inclusion criteria. Adults aged 18 to 60.
Okay.
Crucially, they had to be stable on their existing second-generation antipsychotic medication for at least 6 months.
So their psychiatric condition was under control?
Yes, and they also had to be metabolically compromised already. So overweight or obese, a BMI of 27 or higher.
And the prediabetes factor?
That was key. Their average blood sugar, the HbA1c, had to be in that prediabetic range, 5.7% to 6.4%.
Which means they were already on a dangerous path towards type 2 diabetes.
Definitely. So they recruited 154 of these patients from mental health services in Denmark. It was set up as a 30-week trial.
And the structure?
Placebo-controlled, double-blinded. The standard rigorous approach to get a clear answer.
Now, you mentioned barriers to care. The methodology here had something really interesting to address that, didn't it?
It did. Beyond the standard rigor, the way they delivered the intervention was quite innovative for this group.
This is the part I found fascinating. The actual drug, the semaglutide, given once a week by injection, starting low and increasing to 1.0 milligram.
Or the placebo.
Right, or the placebo. It was delivered entirely in the participants' homes.
By mobile study nurses, yeah. They went to the patients, did the injections, the checks, the assessments, all right there.
Think about what that means for someone who might struggle with transport or keeping appointments, or maybe feel stigma of visiting clinics.
It completely changes the dynamic. It removes huge practical hurdles. And the proof is really in the pudding there. The trial completion rate was incredibly high, 91.5%.
Wow. For a 30-week study in this population, that's amazing.
It really is. It speaks volumes about how much that home-based, patient-centered approach mattered.
Okay. So great design, great retention. Let's get to the results. The primary outcome was blood sugar control, right? The HbA1c levels.
Yes. And the results were, frankly, dramatic. Semaglutide caused a significant drop in HbA1c compared to placebo,
How significant.
an average reduction of 0.46%. That might not sound huge to everyone, but metabolically, it's a very strong result.
But the clinical impact, what did that translate to for the patients?
This is the headline number, really. 81%. 81% of the patients on semaglutide got their blood sugar levels out of the pre-diabetic range.
81%. Back below 5.7%.
Exactly. They essentially reversed that immediate diabetes risk. Compare that to the placebo group.
What was it for them?
Only 19% in the placebo group achieved that.
Wow. So 4 out of 5 patients on the drug basically stopped that progression towards type 2 diabetes.
In a population where developing diabetes is almost seen as inevitable due to the antipsychotics.
Yeah.
It's potentially transformative.
How does that impact the life expectancy gap we talked about? That 15 years.
Well, preventing type 2 diabetes is a massive step. It takes away one of the biggest drivers of heart disease and early death in this group. It fundamentally changes their risk profile.
And potentially saves healthcare systems a fortune in long-term diabetes care costs too, I imagine.
That's certainly the argument the authors make, yes.
And the blood sugar improvements were backed up by weight loss.
They were, very clearly. Patients on semaglutide lost an average of 9.21 kilograms more than those on placebo over the 30 weeks.
That's over 20 pounds.
Yes, translating to about a 7.5% reduction in body weight. That's definitely clinically significant weight loss.
And waist circumference, often a key indicator.
That also decreased significantly by over 6 centimeters compared to placebo. Another sign of improved metabolic health, particularly reducing that harmful visceral fat.
So it wasn't just blood sugar. The picture was broader. Other metabolic markers.
That's right. Lipids improved too. Their good cholesterol, HDL, went up.
By how much?
About 10.8 milli-GDL, which is good to see.
Yeah.
And triglycerides, a type of fat linked to heart risk, went down.
So multiple metabolic benefits stacking up.
Yes, a quite comprehensive improvement in their physical health markers.
And importantly, this wasn't just about lab results. Did the sources say anything about how patients actually felt?
They did. The study measured quality of life using a standard survey, the SF-36. And they found a statistically significant improvement in the physical component summary score for the semaglutide group, about 3.75 points higher.
Is that considered meaningful?
The authors highlighted it as clinically relevant, yes. So patients weren't just getting healthier on paper, they were experiencing enhanced physical well-being too.
Okay, fantastic physical health results. But now the absolutely crucial question for this group, what about their mental health? Did improving the body come at a cost to the mind?
This is perhaps the most vital finding of the entire trial, and the answer was clear.
Which was?
There were no significant differences between the semaglutide group and the placebo group on measures of mental quality of life.
None at all.
None. And critically, no difference in their core schizophrenia symptoms, as measured by the PANIS scale.
So, psychiatrically, it was neutral.
Completely neutral. The physical benefits didn't cause any psychiatric destabilization.
That's huge. That's the green light clinicians need, isn't it?
Absolutely. A clinician's primary responsibility here is managing the psychiatric illness. Knowing you can add a powerful metabolic treatment like this without risking the patient's mental stability, well, that changes everything. It allows for proactive physical care.
Okay, practicalities. Side effects. We know GLP-1s often cause nausea, stomach issues. Was that a problem here, especially with patients maybe on complex drug regimens already? Did it affect compliance?
Well, the sources confirm that gastrointestinal symptoms, nausea, some abdominal pain were indeed the most common side effects reported with semaglutide. But, importantly, the authors noted these tended to get better over time as people adjusted to the medication.
Yeah.
And given that amazing 91.5% completion rate.
Yeah, people clearly stuck with it.
Exactly. It suggests the side effects were generally manageable and the drug was well tolerated overall. Compliance seems to have been excellent.
Any serious adverse events?
The rates of serious adverse events didn't differ statistically between groups. Interestingly, there was a numerical trend, though not significant, towards fewer hospitalizations for psychiatric reasons in the semaglutide group compared to placebo, though this was driven by just a few patients.
Fewer. That's interesting, not more.
Right. Reassuring, certainly.
Okay, let's put this into context. How do these results using the 1.0 milligram dose of semaglutide compare to what we've seen in big trials like SELECT, which looked at obesity in the general population? They use higher doses, right?
They did. SELECT used the higher 2.4 milligram weight loss dose over a much longer time frame in people who were obese but didn't necessarily have diabetes.
So how does the blood sugar effect compare?
This is where it gets really interesting. The HbA1c reduction in HISTORI, that 0.46% drop with just 1.0 milligram, was actually quite comparable to the reduction seen in SELECT with a higher 2.4 milligram dose.
Really? With a lower dose, what does that suggest?
It suggests that these patients whose metabolism is already affected by the antipsychotic medications might actually be more responsive to the metabolic effects of semaglutide.
A heightened sensitivity, perhaps.
Possibly. Their systems might react more strongly or quickly to the intervention because of the underlying SGA impact.
Which really strengthens the case for using drugs like this in this specific group.
It strongly supports the idea that targeting weight and metabolism with GLP-1 agonists should be a central part of preventing cardiovascular disease for these patients.
Makes sense. Now, we always need to look critically. Were there limitations flagged in the sources?
Yes, a couple of key ones. First, the very thing that made it work so well, the home-based intervention with mobile nurses,
Is also a potential barrier to scaling it up.
Exactly. It's resource intensive. Rolling that out universally in standard psychiatric care might be challenging, financially and logistically.
Understandable. What else? Anything about the data itself?
There was one small statistical point flagged in one of the commentaries, kind of a red flag moment for careful readers.
Oh, what was that?
It related to the reported decrease in triglycerides. The paper stated it was statistically significant with a p-value of 0.03.
Okay, sounds significant.
But when you looked at the 95% confidence interval they reported for that change, it actually crossed zero.
Which usually means the result isn't statistically significant.
Correct. The interval going from negative to positive suggests the true effect could be zero, or even slightly in the opposite direction. It was likely just a sign error or typo in the paper, needing clarification.
But a good reminder to always dig into the details, not just the headline p-value.
Absolutely. Critical appraisal means looking closely at the numbers behind the conclusions.
Okay, so let's synthesize this. What's the main takeaway for our listeners from the HISTORI trial?
The core message is pretty clear and very positive. Semaglutide at this 1.0 milligram dose is safe in this population. It doesn't worsen their mental health.
Crucial point number one.
And second, it's significantly effective. It lowers blood sugar, helps with weight loss, and even improves physical quality of life for patients with schizophrenia who are overweight or obese and have prediabetes.
So it directly addresses that metabolic crisis caused by the antipsychotics without compromising psychiatric stability.
Precisely. It offers a viable path to start closing that awful 15-year life expectancy gap.
And the authors felt the benefits preventing diabetes, the weight loss, likely justify the cost.
That was their conclusion, yes. Especially considering the long-term costs of managing untreated diabetes and cardiovascular disease, it presents a really strong candidate therapy.
Okay, that leads perfectly into our final provocative thought for you, the listener, to consider. We know from huge trials like SELECT that the heart benefits of semaglutide seem tightly linked to the weight loss it causes.
Primarily driven by weight loss, yes.
So given these powerful HISTORI results showing safety and efficacy, including significant weight loss, in this very high-risk psychiatric population, how quickly do you think clinical guidelines are going to change? Will we see GLP-1s like semaglutide become a first-line defense against the metabolic side effects of antipsychotics in psychiatric care?
It raises fundamental questions about integrated care, doesn't it? The evidence seems to be mounting that we can't treat the mind in isolation from the body, especially when effective, safe interventions like this emerge. How fast can the systems adapt?
Something to watch closely. We hope this deep dive has given you a clear picture of this important research and what it could mean.
Thanks for joining us.
Thank you.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.